everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Olga Schuth from Monument Health, a plastic surgeon at Monument Health Plastic Surgery in Rapid City. Welcome to the show. Thank you for coming in. Nice to meet you. Now, you're obviously you're not from this area, correct?
Nope.
What got you up here, doctor?
Actually, I'm very far from this area. I was originally born in Russia, Kostroma. It's about 6 hours north of Moscow. Everybody usually asks that question, and then when I say 6 hours, everybody's like, wow, that's really cold. But really, on the map, it's just about 2 centimeters.
Right.
Just like right up there. And when I was a kid, my mom already married an American, and we moved to North Carolina when I was 14.
Okay.
And then I did my training on the East Coast. I did undergrad in UNC Wilmington, kind of small state school.
Yeah.
And then I did medical school at East Carolina University in Greenville. And then I did residency in Richmond, Virginia at Virginia Commonwealth University. That was 6 years. And then I did 1 year fellowship in hand and peripheral nerve in Vanderbilt.
So what led you into this particular vocation or this field? Do you have is there a history of it in your family? Do you have doctors in your family at all?
No, actually not at all. A funny story, when I was a child back in Russia, I changed schools in 5th grade, and there was another new girl, and we sat together and we became best friends, and we made a pact in 5th grade that we're both going to become doctors.
Oh, wow.
And actually we both did. She stayed in Russia and she finished her medical school in Moscow, and I came here, and I think both of us were very fascinated by biology class. We sat together and loved biology, and combining that with helping people is a very unique profession. Specifically, I always knew that I was interested in surgery. I like the fast results. There's a clear problem in front of you, and you have the skills, in hand maneuvers to fix that problem, and the payback is very quick, and it's very, good incentive. However, when I got to residency, or even medical school, rotating through different surgical subspecialties, I realized that I didn't really quite have the gut for, the more intense general surgery, people dying in front of you, people, losing limbs. However, plastic surgery is very creative, and they say that plastic surgery is the last true general surgery subspecialty, because you get to operate from cradle to grave and from head to toe. So most people, when they hear plastic surgery, just think, kind of cosmetic, boobs and butts.
Right.
But in reality, cosmetic surgery only comprises about 1/8 of plastic surgery subspecialty. So there's a lot more fascinating things within plastic surgery than just more superficial cosmetic stuff, which I also still do.
Right.
But yeah.
Well, yeah, and that's kind of what one of the things we're going to talk about here today is that peripheral nerve release coming up. We could make this whole podcast, though, Doctor, because I believe where you came from in Russia was the birthplace of the Romanovs.
Oh, I'm very impressed that you
it?
know that. That's exactly right. Yes, there is a cathedral near to my hometown. I'm blinking on the name right now. Ipatevsky Monastyr.
Okay.
That's what it's called. And it's a monastery where the Romanov family originated from. Yeah.
It's in 300 years, I think they ruled Russia
for a
right?
long time. Yeah.
And then of course the shocking end to that entire family is what everybody still talks about today. Anastasia, of course, always seems to pop up. But did you learn a lot about that when you were growing up there? Did they teach you a lot about the Romanovs while you were there too, and its background and story and everything?
Yes, it was part of the culture. Like kids here learn about American Revolution,
right.
And in Russia we learn about the Romanov family, and we've had school trips that we would go to that monastery, and I've been there with my parents just for like a weekend trip.
So it's
very beautiful.
It's worth visiting.
Oh yes, very beautiful, very
okay.
old. Another kind of interesting thing. Me and my husband have been back. My husband is a Russian historian.
Oh wow.
We met in college, and I don't know if it's my fault or not that he became a Russian historian. But when we went back, one fascinating thing about these like smaller monasteries in Russia is that nothing's really protected. You go to a museum here or a museum in Europe, and everything's kind of behind lots of glass, and you can't really see. There in monastery, there's barely any people, and there's something like 600-year-old, icon that's just hanging there, and you can, you shouldn't come up and touch it, but you can, you can really get really up close and personal with stuff, and kind of really get hands-on with the history.
Well, now I know the next vacation I'm taking. I
Well,
want
I
to go
would
there
wait
so
until
bad.
then.
That'd be great.
Yeah.
Oh, yeah.
Until the
Wait
war's
until
over.
some things have calmed down, of course, for sure. But all right. Well, like I said, this is not what this podcast is about, although we could talk about that for a long time. We're going to talk about peripheral nerve release surgery. And when I saw the topic pop up, Doctor, it said, I saw that you were a plastic surgeon. I saw peripheral nerve release. I thought, oh, this must be something with, like you had mentioned, like the hands and things like this. But this is for targeting migraines, correct?
Exactly. Yep.
So explain how this works, I guess.
Yeah, so very interesting history to it. And again, I feel like in plastic surgery, whatever other subspecialties you don't want to touch, it usually ends up with plastic surgery. Right. But basically, the idea is that not all migraines and headaches come from within the brain, within intracranially. Some of them can result from compression or irritation of the peripheral nerves that simply supplies a sensation to our scalp. So we have several nerves all around our head that supply sensation to our scalp. The most commonly ones that are involved in migraine surgery are occipital nerves. So there's greater and lesser and third occipital nerves that originate kind of behind your base of your neck, base of your skull. And all they are supposed to do is just carry sensation from the back of your scalp. So, if something brushes against your hair, you know what's going on in the back there. However, because they have a rather tortuous course through some muscle, through some fascia, sometimes they can get irritated. They also sometimes run together with an artery. So, for example, if the nerve is already kind of irritated and runs really an intimate course with the artery, let's say your blood pressure goes up, that artery starts pulsate harder, then it irritates the nerve that lies adjacent to it. That nerve causes you to have pain, which further increases your blood pressure, which further increases the irritation of the nerves. So it's kind of positive feedback loop mechanism. So the story behind why plastic surgeons got involved with it is there's a famous plastic surgeon who was doing a lot of eyebrow lifts and eyelid lifts probably about 20 years ago. And he had great results, and his patients would come to him and say, "Hey, doctor, I love the way I look now. However, incidentally, also my migraines are gone." So these patients used to have frontal migraines that would originate due to supraorbital, supratrochlear nerves that are, again, they're just designed to carry sensation from your forehead. And they would be the cause of this patient's migraine, and the plastic surgeon would release, resect some of the corrugator muscles that look good, that cause us to have these number 11 wrinkles. And they would get resected as part of the cosmetic surgery, and inadvertently either the nerve would be released or decompressed. So that's how, and then people started focusing on it, and that's how the migraine surgery became part of plastic surgery.
So finding it in the front accidentally, kind of in a way, and then you guys just thought, well, if it works there, then let's try.
People started
around
investigating
the rest
it.
of the head.
Yes, around the base of the
So then, what types of people are considered, ideal candidates for this? Are there certain symptoms that makes someone a good fit?
Yes, that's a great question, because again, most of the migraines, or a good percentage of migraines do come from intracranial causes that will not be relieved by decompressing a nerve. However, all of migraines and headaches should be primarily diagnosed by neurologists. Patients should not come to me for a diagnosis of their headaches. However, a patient population, for example, would be somebody who was living their life being fine, and all of a sudden they got in a car accident and suffered like a whiplash injury. And then several months later, they started noticing that they have this dull, unrelenting pain in the back. They can pinpoint with one finger exactly where it starts. It radiates to the forehead all around. Sometimes they report that pressure when the migraine starts, putting some pressure helps. Sometimes they can report that putting some ice at that trigger spot helps. And they can literally pull with one finger exactly where it starts. And they'll see a neurologist, and the neurologist can actually refer them to pain specialist, and the pain specialist through anesthesia will inject them with some blocks. So block is just a long-acting anesthetic like lidocaine. Seems that the dentist injects into your teeth to numb up your teeth. I can do this, or anesthesia pain service will do it. They will inject them, and if a patient has good relief with this block, with this injection, it's indicative that it's coming from irritation of one of the nerves, whichever one that got injected.
Right.
The sad part to all this is that the nerve block wears off. So most of the time, patients say, I felt great for a couple of days, maybe for a week, but then my pain came back.
So is it almost a constant type of pain, or is it a pain that comes and goes?
It's usually more daily, and
Okay.
usually patients describe it as relenting. The forehead, if you have a trigger with supraorbital, supratrochlear nerves in your forehead, patients describe it as just exploding.
Okay. So when you determine that that's what it is, they've come in, they've pointed to it, they've tried the lidocaine, and you think, aha, I know exactly what this could be. Then how does that process start?
So then I will examine the patient again.
Okay.
We will have a discussion, just make sure that where they point to correlates with the known nerves. I will hear their story and make sure that it's something similar to kind of the story that I told you, an exciting event. If we're talking about forehead, usually people have deep creases from overactive muscles. And you're thinking, oh, they have well-developed, corrugator muscles, could be potentially entrapped nerve. We'll discuss me repeating the block. Sometimes in clinic, I'll ask patients to come in exactly when they have a migraine, and I'll block them myself in clinic, and patients will be like, oh, I feel so much better. That helped. We could discuss non-invasive interventions such as Botox. So the way that Botox works is, for cosmetic purposes, it works by blocking the blocking the muscles, paralyzing the muscles. So same idea, if you think that the muscle action irritates the nerve, some patients will get better with Botox, Botoxing the area around the nerve. However, in patients in whom that migraine may be coming from just a very intimately adherent blood vessel, that may not help. So the Botox is not as crucial in my diagnostic toolbox as the block. And I'll have a discussion with patient about what it all entails, a surgical intervention. So we'll discuss, what kind of incisions it'll be. For the back, it'll be incision transverse on the base of their head. We'll have to shave some of their hair so that I can see what I'm doing. And we'll talk about, all of the dissection is relatively superficial. So I'm going under the skin and into the muscle. I'm not going into the brain. I'm not going into anywhere close to their cranium. I'm not going anywhere close to their spinal cord.
It doesn't seem like you have a lot back there to begin with, though.
You don't.
So that has to be, yeah.
So maybe that's why the nerves are getting trapped, because there's not a lot of room.
Right, sure, exactly.
Yeah. So that's kind of the discussion that we have. We talk about surgical risks, right? Every surgery has risks.
That'd be my next question there.
There's always a small risk of bleeding, small risk of infection, small risk of damage to surrounding structures, need for repeat surgery. Those are our standard ones. Almost everybody will experience some sort of paresthesias in the distribution of that nerve. So again, remember your occipital nerve supply sensation to your scalp. You may have some electrical sensations, or you may have some numbness in the area of that nerve, because when I'm releasing that nerve, I really have to kind of manhandle it, move it side to side to make sure that it has a good pathway to go through.
Now, you've said release the nerve. What exactly does that mean?
That means the surrounding, basically like a wrapper. In order for you to get to your candy, you have to unwrap the wrapper. So same thing, the wrapper being just connective tissues of your body. So be it fascia or be it sometimes through the muscle. Most of the time, you are releasing the nerve for about 5 to 10 centimeters. So you're releasing it from where it comes into the muscle. So it may involve cutting out a little postal stamp size muscle. You're releasing it from the fascia. If there's an artery that's running next to it, then we clip the artery to just get rid of it completely. And we chase it all the way down into the subcutaneous tissues where the nerve branches so much that you can no longer follow it.
Right. What does a nerve look like?
It's a noodle.
Is that what it is?
Yes, I love people asking that, because literally it looks like a noodle. That's all it is.
But you can see them with the naked eye, can you, in most instances?
Yeah, exactly. So you have big nerves and smaller nerves.
Okay.
So the big nerves, when they come out from your spinal cord, they're very big, and then they branch and branch and branch, just like your blood vessels, until the nerves that supply sensation to your fingertips are so small you wouldn't be able to see it without a
Really?
microscope.
Okay.
But the nerves, when you're talking about even digital nerves, the two nerves that are right here, they're small, about a diameter of 1 millimeter, but they're still, you can see them with a naked eye. I wear loops, so I have 2.5 magnification loops just to allow me to, view it better. But you can easily see it with a naked eye.
Okay.
The way I kind of like to think about a human body now that I've gone through my training is basically it's a meat bag. You're operating, you have a brain that's sitting in a dark box. And in order for the brain to collect information from the surrounding world, we have our organs, right? And we have nerves that carries the information into the brain. The brain itself doesn't know anything. It's sitting in a black box. And then in order for the brain to to manipulate our environment, we also have noodles that are running out of the brain, out of the dark box, into the meat bag in order to move our muscles around. All we are is just a meat bag.
That's true. That's very accurate. Our nerves, it seems like they're hard to work with in a sense that because you'll talk with people that have chronic pain, right? That's nerve related or nerve damage, or people that get like shingles, and that's a nerve damage condition, correct? I mean, are they a hard part of the body to work with, or do you find with what you do, it's relatively?
It's relatively forgiving.
Yes.
Nerves are relatively resistant. There is a certain amount of regenerative potential.
I was gonna say, do they grow back sometimes?
They do, not in a sense, not as easy as skin.
Okay.
But in a sense, they do recover. The younger you are, the better they recover. The healthier you are, the better they recover. So right now, we're all worried about metabolic syndrome. So somebody with diabetes, where you have or insulin insensitivity, where you have a bunch of sugar floating around in your body, that's going to inhibit wound healing potential and nerve healing potential for sure. Diabetics have peripheral neuropathy, where they have a lot of glucose deposition on their nerves, so they don't work as normal anymore. But nerves are relatively forgiving. I also do a lot of peripheral nerve releases for carpal tunnels and cubital tunnels. Cubital tunnel being the cousin of carpal tunnel, where it's compression of the ulnar nerve at the elbow.
I've never heard that one at all. No, that's new.
So the ulnar nerve supplies sensation to your ring and small fingers, and it's also responsible for the fine motor activity of your hand and strength. So the easy way to test it is spread your fingers and resist them being pulled back together. So if you can resist that means you have good ulnar nerve function.
Got it.
Yeah. So those nerves are pretty big. So we're talking about 3 centimeter diameter.
Yeah.
Be very easy to see around the elbow, and people will come in with numbness and tingling in the small and ring fingers, but also some intrinsic motor dysfunction. So after releasing the nerve, what mostly improves almost right away is kind of paresthesias and numbness and tingling. And then the motor component takes up to several months to get better. So nerves regenerate 1 millimeter a day. Wow. So if you have an injury at the elbow, by the time it gets to your fingertips, we're looking at several months.
Oh, I see.
Yeah, so nerves do regenerate.
Okay.
They just take a while longer. They are forgiving to work with, but you do have to be careful. They also have a protective layer wrap around the actual cables themselves, so you can, gently grab it and manipulate it, but obviously you don't want to crush it.
Right. Well, I'm picturing like wires.
Yeah, that's exactly.
That's
wires that control your meat bag.
Yeah. What's the what are the long-term outcomes for this as far as migraines go?
Yes. So 85% of patients, except the most good data we have is for occipital migraines. And for 85% of patients, they can get off at least some of their medications, and 50% of patients can expect a cure.
Wow.
In my practice so far, what patients say is about 75% improvement. Okay. So not everybody's going to get cured, but you're looking at least for some more active days, some more days without debilitating symptoms, and ability to get off some of their medications.
Okay, excellent. Well, that's, what you do, digging in, finding those nerves, being able to in essence, turn them off, I suppose, a little bit. For people with migraines, I can't imagine. Are they considered to be, I don't know how much you know, specifically about migraines, but are they considered to be like the worst type of headache you can get? I don't think I've ever had one, so I can't really relate. But they've got to be pretty bad.
Well, the thing about pain is it's very subjective.
Sure,
right?
Of course.
So
yes.
some people tolerate pain better, some people tolerate pain worse? I think it's probably impossible for one person to say what kind of pain is the worst because we're all so different. I think it's probably a better answer for a neurologist. Like I know that a headache that comes from like bleeding into your brain is pretty bad as well.
Oh, I suppose.
So, yeah. But yes, migraines are, depending on a person, can be very debilitating.
But it's just nice to know that there's something out there that can fix it outside of just constantly having to take medication. Because I think in a lot of instances, that's what people they want to get off it. They don't want to take it all the time.
Correct. If your migraine is caused by peripheral nerve compression.
Right.
Yes.
Exactly. Well, Dr. Schuth, it's been great talking with you. This has been very interesting. Yeah. And I'll when we're done talking here, I want some places to visit. In Russia when we all can get along. Right? Yes. So thank you very much, Doctor. I really appreciate this, and I hope to have you back.
Yeah, awesome.